Good morning, everyone, or good afternoon, wherever you are, and welcome to our presentation today. I just want to make sure that you can hear me. So if you can type into the chat that you can hear me, we can get started. And there's a bit of a delay, so I will just wait to see if, good, Diana says yes, Genevieve says yes, Tracy, Eve, Eva. See, Eva, I knew it was you. Barb, Wendy, Cole, yes, lots of good yeses. Excellent. All right. Okay, so I'm going to pull up the PowerPoint. Now, as you can see, Marina's not here. And generally, Marina's job is to let me know if there are any hiccups while I'm presenting, because once the power is up, I can't see the chat. So I'm just going to put in, I need my cell phone, just a second. I'm just going to put in my cell phone and sorry about that. I meant to have this with me. I'm just going to put in my cell phone number, and somebody can send me a text if something goes awry. And what I'm looking for is if multiple people are having an issue. If it's just you, and you'll be able to tell from the chat, because normally people in the chat will tell you that they're fine. So if they're fine and you're not, then it's either a browser issue for you or the connection that you have. And there's a reconnect button on your screen. It's either at the top of the screen or at the bottom. Depends on which browser you're in. If you just hit that, you know, say I froze up or something like that, just hit that, and that usually brings it back to where it is. So with no further ado, I am going to bring up the PowerPoint. And there it is. And I'm going to allow that. And so hopefully you can see that, right? You can all see that. And I'm going to go to reading view. Okay, we're good? We're good. Okay, so I'm going to start. So we're going to be talking about SIBO and candidiasis, kind of the differences between the two and the protocol differences and similarities, and, you know, basically how you sort of deal with these two conditions. I'm sure, as you're aware, SIBO has become the new Candida. So everybody's like assuming it's SIBO now instead of Candida, and it makes it very confusing for people. And what I'm hoping you get from this particular presentation is it doesn't matter that much, because in general, what you're going to be doing for either one is quite similar. So today we're going to just review candidiasis and SIBO, causes and symptoms. I've got some new info on SIBO, and we're going to compare the protocols. So I'm just going to do a quick review of candidiasis. Most of this you probably already know. So candidiasis is a condition of yeast overgrowth. Generally, the yeast that has overgrown is Candida albicans, but it's not necessarily just that, and it's not necessarily Candida. But Candida albicans are quite prolific and virulent, and that's why they tend to be the ones that are causing the problem. Now, yeast is natural to our gastrointestinal system. We also have it in our mouth. So we have it in our mouth, small intestines, large intestines, and in women in their vagina. I have heard some information that it might be in the urinary system as well. Doesn't really matter. It's natural, and it can perform. There are good yeast, there are bad yeast. The good yeast help us. The bad yeast may be problematic for us, but only if they get out of control. So as long as there's sufficient good bacteria, you don't have a problem. So yeast can only be in excess if there is too little good bacteria. Yeast does have a more synergistic relationship with bad bacteria. They both live at a pH, or ideally live at a pH in the intestinal tract that is slightly more alkaline than what good bacteria likes. And good bacteria generally secretes lactic acid, which keeps the pH a little bit lower, making it more synergistic for good bacteria and not so good for yeast and bad bacteria strains. And this is how, one of the ways it's kept in balance. There are other little tricks the good bacteria has in its arsenal that it can, you know, actually eliminate bad bacteria and eat yeast, and there's all kinds of other tricks it can do. But in general, in a healthy gut, there is a synergy with the yeast, the bad bacteria strains, and the good bacteria strains, with the good bacteria basically in control. Now, if you have Candida or Candidiasis and it gets into the blood and it reaches vital organs, it can actually be fatal. And I'm sure you're familiar with all the symptoms of such as food sensitivities, headaches, joint pain, skin issues like eczema, acne and rosacea, heartburn, nausea, mood issues, brain symptoms, so it shows up in autism, Parkinson's, Alzheimer's, you know, things like that. Respiratory issues such as asthma. Of course, you have the gastrointestinal problems like constipation, diarrhea, gas, bloating. Often people with candidiasis will have other fungal infections, such as toenail or maybe a skin fungus, or they may have yeast infections, vaginal yeast infections. They may suffer from oral thrush, which is, of course, basically candida in the mouth. And there's a lot of overlaps with people who have candida who also have allergies or autoimmunity or hormonal issues or diabetes. And it's often found in cancer patients as well. So this is not something that should be taken lightly, and it is fairly reasonable to try and eradicate it, but you know, it can, if not, you know, if you don't look after it, it can actually be quite serious and be contributing to a lot of symptoms that cause people a lot of problems. So the cause, of course, as I mentioned, is insufficient good bacteria, or what we call dysbiosis. Antibiotics is obviously probably the most common understood means by which one would have a problem with yeast being able to overgrow because the good bacteria has been depleted. Steroid drugs play a role. This would be including prednisone or any kind of corticosteroid or birth control pills. That's a little more complicated. It's not as direct as an antibiotic. You know, the effects of antibiotics can be seen very quickly after a couple of courses, whereas a steroid drug would be damaging the intestinal wall lining over time. And so this can cause the problem down the road. This is really important because, you know, we try to blame, you know, sugar and, you know, other things like that as being more direct. They're actually not direct at all. But if you eat a processed refined diet as opposed to a whole foods diet, you're not feeding your good bacteria sufficiently. And this is the residential good bacteria that lives in you naturally. And if you don't feed it, then how does it keep its numbers up to keep the yeast at bay? So it's really important that we talk about this because, you know, when people try to blame sugar, then they look at things like honey and maple syrup and assume that they are as problematic because they're sweet, but they're not, because they actually have things in them that support the good bacteria. Maple syrup has prebiotics. Honey, raw honey, actually has strains of good bacteria in it. And other phytonutrients that are found in things like coconut sweetener and sucanat, they're all showing now in the research that phytonutrients, along with different types of fiber, actually promote the growth of residential good bacteria. So we're talking whole food diet versus processed refined food diet, lots of nutrients versus not enough nutrients. This is the factor for candidiasis with regard to diet. And then, of course, there's gut motility issues. So if people have a slow transit time, or the muscles in their gastrointestinal system are irregular and they don't work very well, this is problematic for people, and they may develop candidiasis. Okay, I put this up here just special for you guys because when I was doing my research for this, I happened on the CDC website. That's the Center for Disease Control and Prevention. This is the one that's always on the TV whenever there's an outbreak of any kind of bacterial problem, or you see them on TV shows, they're always being quoted, or if you watch The Walking Dead, they were blown up in the first season. So this is the big center in Atlanta where they house all the different strains and of viruses and bacteria and everything, and study them with regard to developing vaccines or even evaluating vaccines. They do all kinds of work like that. And this is on their website. So a lot of times we're told candidiasis does not exist. The medical community doesn't recognize it, et cetera, et cetera. But the CDC recognizes it, and there it is, right there. You can see it for yourself now. So I thought that might make you feel good that we're not, this is not a made-up condition. Okay, but while I was on the CDC, I came across something new. And this is another yeast strain called Candida auris. And the CDC is labeling this a new emerging global threat, okay? So it's a rising issue. And it's really difficult to identify with standard lab tests. And it has caused outbreaks in hospital settings and can spread patient to patient, something candidiasis with Candida albicans cannot do. So this is kind of new for yeast and kind of interesting. Most of the strains of this Candida auris are treatable with antifungal drugs, but what they're starting to see is resistant strains developing. So very similar to what we've seen with antibiotic resistance, there's now antifungal resistance when it comes to this particular Candida strain. So the reason this is interesting, or at least to me, is it's not found in nature, so you can't find it in the world around us, and it has not been known to exist naturally in the body. So we do know that organisms mutate and evolve, and this has evolved. We have created this in our system. Now, it can live on surfaces for a month, which is kind of unique. Bacteria can only live on a surface if there's no moisture present. Bacteria can only live on a surface for 3 hours. And chemicals like ammonia, so a lot of cleaning chemicals, especially those used in the hospital, have ammonia in them. They don't work. And they're now saying it's responsible for 40% of the Candida infections. Now, as far as symptoms and causes go, there are no obvious symptoms because this particular Candida problem generally occurs in people who are already sick. So it mainly affects patients who have many medical problems, and they're generally in the hospital. And so it's most seen when people who have frequent hospital stays, but it also exists in nursing homes. Healthy people usually don't get it. So again, this is just strengthening our desire to have a healthy microbiome and to be working on the gut and to, keep it healthy. It will affect patients who have weakened immune systems, and it can be from conditions such as blood cancer or diabetes. It also can affect people who've received lots of antibiotics. They're at higher risk. And then people who have devices like breathing tubes, feeding tubes, catheters in the vein or a bladder catheter, these are the people who generally are developing this type of Candida problem. Oh, sorry. So I thought there was one more slide. There isn't. So I don't really want people to, be freaking out about this. I just think it's interesting that, first we have bacteria that becomes resistant, and now we're seeing some yeast strains that become resistant. And again, it's in the same people. It's people who are really sick and people who are in places where people are really sick, like hospitals and nursing homes. And I think the source of the problem is the same. And we're just going to talk a little bit more about that later, but I just thought that I should point this out to you. All right, so now we get to move on to SIBO. So, as I'm sure you know, SIBO is small intestinal bowel overgrowth, and basically it's a chronic bacterial infection in the small intestine. It's caused by bad bacteria such as E. coli and Clostridium migrating from the large intestine to the small intestine. So your small intestine is not a natural home for a lot of these, what we'll call pathogenic strains or bad bacteria. And there's a mechanism to keep them out. And if they find their way in and there's nothing to stop them from proliferating, this is what causes SIBO. So generally, there is not enough good bacteria to deal with these strains in the small intestines, because remember what I said before, that good bacteria has some tools in its arsenal to keep bad bacteria and yeast at bay, including lowering the pH of the overall environment so it's not synergistic for pathogenic bacteria to reproduce. So it always has to be remembered in this context. Good bacteria, sufficient numbers, no problem. Not enough good bacteria, problems start to come. Now, the reason it's easier for it to proliferate in the small intestines is because the numbers of good bacteria are quite low. There's considerably less good bacteria in the small intestines than there is in the large intestines. And the reason this is the time spent. So if you're having food move its way through your gastrointestinal system, it's only in the small intestines for, maybe an hour or two, whereas it can be in the large intestines for up to 18 to 24 hours with, good transit time. So what that means is that strains of bacteria that are found naturally in the small intestines, they don't have huge amounts of time to proliferate before everything is moving into the large intestines. And the food that they feed off of is not there as long for them to feed off of. So the numbers are much lower, whereas there's plenty of time because a lot of what is passed from the small intestines into the large intestines, the residue of our food, the fiber, etc., is containing food for the gut bacteria in the large intestine. Because there's so much time there, they proliferate much more extensively. And so you have many, many more good bacteria and even pathogenic bacteria in the colon than you do in the small intestine. So it's a better ground for E. coli or Clostridium to be in to populate. You really need to have good levels of good bacteria in the small intestine to protect that. Okay. So when you have this pathogenic bacteria in the small intestines, it's going to interfere with nutrient absorption. They can also damage the gut lining, and this is part of the reason why the nutrient absorption is affected. They play a role in leaky gut. They also interfere with bile acids. So bile acids are often carrying fat-soluble vitamins, for example, and they can be deconjugated, and as a result, you don't have as much availability of your fat-soluble vitamins. So a lot of interference going on there. They're also competition, mind you, so is the good bacteria as well for our nutrients from our food. The difference is that a good bacteria may use B vitamins or certain vitamin D or whatever, but then they turn around and produce something that's very useful for us, whereas bad bacteria doesn't do that. So symptoms, very similar as to what we saw before: food sensitivities, headaches, joint pain, skin issues like eczema, acne, and rosacea, heartburn, nausea, mood issues, brain symptoms, again, autism, Alzheimer's, Parkinson's, respiratory issues, asthma, anemia. Because of the interference with the nutrient absorption, you can have iron deficiency or B12 deficiency. And undigested fat in the stools and weight loss can also be symptoms. SIBO has been linked to conditions like diabetes, gallstones, heart disease, autoimmune. All of these conditions have been linked to dysbiosis, not necessarily candidiasis, but definitely dysbiosis. So, and basically most health conditions that are outside of the actual gastrointestinal system have been linked to dysbiosis. So, whether it's SIBO or whether it's dysbiosis, neither situation is good. And as you can see, many of these symptoms are very similar to candidiasis. And this is what makes it so difficult for people to sort of figure out whether it's candidiasis or if it's SIBO or if it's both, or right. And yes, there is that hydrogen breath test that you can take to determine if it's SIBO. But there's two out there, and the one that we can use is not considered very conclusive. So I wouldn't be getting too hung up on that. As you're going to see when we get into the protocols, it may not make that much of a difference whether it's SIBO or candidiasis. It's more, what are you going to do for the client? Okay, so causes. First of all, it may be more common in people who have some type of intestinal anatomy issue or intestinal muscle issue. So, for example, this could include anatomy changes that are caused by gastric bypass or intestinal bypass. And I'm asked this all the time, is what happens to the gut? What is the effect on the gut if somebody's had gastric bypass or, an intestinal bypass? And the problem is they may develop SIBO. Anything like diverticulitis, tumors, or any other type of bowel obstruction, this can be a factor. A big one is the ileocecal valve. So the ileocecal valve, for those who don't know or may not remember, is the valve that separates the small intestine from the large intestine. And as food material or the waste or the remnants of the food is moving from the small intestine into the large intestine, the ileocecal valve opens up, stuff flows through, ileocecal valve close, nothing from the large intestine can get into the small intestine. But if you have any kind of interference with regard to the ileocecal valve, be it due to some type of surgery issue, or the muscles are not working well and the valve's not opening and closing properly, or if the gut motility has slowed down so that it takes longer now for the stuff to move from the small intestines to the large intestines, and therefore the valve is open longer. These are all reasons why the ileocecal valve can be connected to SIBO, and the bad bacteria from the large intestine has the opportunity to find its way into the small intestine. There are a lot of drugs that affect gut motility, and this is the thing that really made me want to do this particular webinar. And I'm going to talk a little bit more about what drugs, because we talk about antibiotics and we talk about corticosteroids and things like that, but a lot of people are on a lot of different kinds of drugs, and we don't know enough about the effects they're having on the gut, and if this is something we need to be aware of, because if this is what's in our client's history, even if they aren't taking them now, they may have taken them before, and that could be playing a role of how they are behaving in front of you, the symptoms that they have now that they're coming to you with. And if you don't know that some of these drugs may have played a role into how they are today, then it's going to influence what kind of protocol that you do. And then there are opportunistic infections that can be either caused by antibiotics or non-antibiotic causes. So basically an opportunistic infection is an infection caused by bacteria that is native to us. E. coli would be an example, Clostridium. And basically, they're waiting for an opportunity to multiply, which of course is what causes us to get the infection or the condition related to the infection. So this can also be connected to SIBO. All right, so we have a nice little diagram here that really sort of gives you a picture of what can happen. So the top picture is the healthy microbiome. You can see all the diverse microbes at the top of the picture, and then you kind of see the blue thing there. Sorry, I'm trying to get this stuff here. This is the mucosal lining, and then below that with the pink is the intestinal, the cells of the intestinal lining. And if you go to the next picture, this is after a course of antibiotics. And what you're seeing is a reduction in the diversity if you compare the top to the middle. And then the little pink things there are C. diff. And so you can see how easily it proliferated. And then you can see that the C. diff now is affecting, it's inflaming up the intestinal wall lining. It's actually getting access into the intestinal cells. And so this can damage the lining. There are toxins being produced that damage the lining, and this can lead to colitis and even cell death. Now, antibiotics can increase the free sialic acid that we produce naturally as the host and succinate from the microbiome. So specific bacteria produces succinate. Now, I was going to do a slide on what sialic acid was and succinate acid was. And so I was going through the information on it, and quite frankly, it's so technical and not really something any of us want to deal with on a Sunday, that I thought, you know what, it really doesn't matter what they are. They are organic acids, I'll tell you that much. But they're not necessarily something, if we're looking at the overall health of the gastrointestinal system, it really doesn't matter if it's sialic acid or succinate or whatever it is. If we're not allowing the system to do that, then we don't have to really concern ourselves with it. And I just thought, you know, let's be nice on a Sunday, and I don't want to go there. So if I don't want to go there, I'm sure you don't want to go there. But what we need to know about these is that they encourage another type of pathogenic bacteria called S. typhimurium. And if you again look at the third picture, you can see that particular strain is proliferating. And you can also see the C. diff as well. And this particular bacteria has been linked to gastroenteritis. So elevated succinate and sialic acid also allow C. diff to proliferate. So this means a person could have colitis and gastroenteritis all at the same time. And you can imagine that would be quite a lot of discomfort present. A lot of damage being done to the gut lining, a lot of damage being done to the mucosal lining. So this is sort of what can occur when these situations are allowing to proliferate. And if this is happening in the small intestines, then you can understand why SIBO would be causing so many problems for people. Now, this is just one path where some type of chronic infection can lead to disease. And I just thought this was really good to sort of highlight. So a lot of us may have, and there's a big theory out there right now that a lot of us are suffering from a very low grade chronic infection, nothing that is, you know, overwhelming, that, you know, gives us a fever and, you know, major symptoms, but it's just kind of consistent. So I picked sinusitis, for example, and so that would be somebody who's blowing their nose frequently and they may suffer from sinus pain. If they go on an antibiotic treatment, whether it's one course or multiple courses, that's usually the path, especially if the sinus pain gets too painful or there's headaches or whatever. Doctors would often recommend an antibiotic. Once they've had 2 or 3 courses of antibiotics, the GI issues start. So this is going to severely disrupt the diversity of the microbes that are available in the gut, and then your gut motility will slow down as well. So this now provides a foundation or a good backdrop for the development of SIBO. So this is especially with slow gut motility, which really increases the opportunity for bad bacteria to come into the small intestines, you know, based on what I was telling you about the ileocecal valve. From there, food intolerances start. So SIBO can lead to poor intestinal immune function and intolerances. And so let's say it's gluten. It could be another food, not picking on gluten here. So once you have these food intolerances, what often happens is people will have a single exposure to an intolerance, and then all of a sudden some symptom comes. It could be skin issues, like they break out in rosacea, or achy joints, or some other symptoms that they think, oh, it's the food. I ate this and this happened. And over time, this can lead to more severe diseases as well. And again, they're linking it back to the food. But if you look at this chain of events, you can see it's not the food. It started way back up there, and it started with those antibiotic treatments. And so this is sort of what we have to kind of unravel an onion That's what I call it, where we're going back in time to seeing all the different things that a client may have gone through that could be influencing where they are today, and not just going to, oh, the food causes the problem, therefore that's the solution. It's not the solution. Removing gluten, if you have a gluten intolerance, doesn't improve your gut motility. So these are really important considerations. Okay, so we were talking about non-antibiotic disruptions of the gut microbes. So those are all those things I listed with causes of SIBO, like the surgeries or the drugs that interfere with gut motility, which interferes with gut microbes. So there's other causes to why you have a disruption of your gut microbes. So this can also lead to these opportunistic infections that we were just talking about. And if you have a reduction in gut motility, it can also be due to dietary changes, travel, medication. And I'm sure you've all experienced where, you go on vacation, you're all excited, and the next thing you know, you can't poop. So that's a sign your gut motility has reduced a bit. And that's not necessarily permanent, but it still shows you how easily it is for this system to sort of get out of balance. The lack of diversity of the gut microbes, no matter what the cause, antibiotics or non-antibiotic, also increases the production of the succinate, as we already talked about. And it's by a bacteria called, and I'm only going to try and say this once, and then I'm never going to say it again, because again, I don't think you say big words on Sunday. It's, we're supposed to be relaxed here. So that is Bacteroides theta-ioteomicron. That's probably not the best way to pronounce it. But for now, I'm just going to call it B theta. Isn't that nice? That's a good word for Sunday. So this is a really interesting bacteria, which I'm going to talk about on the next slide. But succinate also helps E. coli. So we saw it helped another pathogenic bacteria before, and C. diff. But it helps E. coli and C. diff become infective. So it like strengthens them, if you want to look at it that way. Interestingly, B theta can digest small parts of the mucosa, increase a chemical called fucose, and this will actually lower the virulence of E. coli, so the infection isn't quite so bad. So that's kind of interesting. But there's more. So I picked this one because it's a really good example of a pathogenic bacteria, which is usually a gram-negative bacteria. That's how they sort of describe it. And they have roles. So there's the strain when it's at its normal levels, and what it does then. And then there's the strain when it's at high levels and what it does to us. And it's kind of a yin and a yang. So it's really complex. And these are bacteria that are native to us. So they live in us, they belong in us. They're called commensal, which means that they are part of our residential bacteria. So on the plus side, this B theta helps break down plant polysaccharides, grow new blood vessels from pre-existing vessels in the gut, aids absorption of nutrients, and helps baby develop their intestinal lining. So those are all good things, right? But on the negative, so that's when it's at its normal levels. When it's on too much, when you have an excess, it's the most common cause of infection and is associated with peritonitis and septicemia and poor wound healing. So if you have wound infections, it's often linked to this particular strain of bacteria. It easily proliferates because it's antibiotic resistant. And of course, it produces the succinate, which we've been talking about, which increases other bad bacteria strains. So we have a lot of this going on in us. This is just one strain. This is just one type of bacteria. But I thought it was important that we see it in this light, that when it's in its small numbers, it may be doing something helpful as part of the team. And I once heard that, analogy made that when you're looking at good bacteria and bad bacteria, when the good bacteria is in charge, it kind of forces the bad bacteria to play nice in the playground, which means they are helping, they are doing something beneficial. But the minute they kind of, get some free will and can run amok, that's when they start to do the damage that we associate with them. And so I know that kind of is overwhelming a bit. It's overwhelming to me to think about, well, this is so complex. But again, it doesn't change what we do, and it doesn't change what the good bacteria needs and how we inhibit bad bacteria. That doesn't change, and that's all we kind of have to focus on. All right, so this brings me to the drugs that affect gut motility. So you have your anticholinergic drugs, which are things like Benadryl, Artane, Anafranil, Thorazine. These are all antispasmodic drugs, and that makes perfect sense because, if gut motility is about muscle contractions and antispasmodics control how muscles react, you can see how, and that not just in the gut but elsewhere, you can see how this might affect gut motility. Tricyclic antidepressants, Tofranil, Vivactil, and Elavil. The B-adrenergic agonist drugs, I don't know why they have these lovely names for them, but these are basically asthma drugs, so Alupent, Brethine, and Proventil. And then this is the one that caught my attention, opioids. So you see all the big guys there, OxyContin, Percocet, Paladone, Vicodin, Percodan, Tylox, Demerol, these are all painkillers. You know, we have an opioid epidemic right now in North America, but that alone isn't an issue for me. It's an issue, but what I'm saying is that this list doesn't include the Tylenol 1s, the Tylenol 3s, the 222s, which people can buy over the counter. And if you know anybody who takes these kinds of medications, they can be easily abused because there's nobody monitoring them because they're not by a prescription. And so we have to take those into consideration as well. A lot of these have codeine in them, and codeine, I can tell you right now, is lowers your GABA levels and lowers your acetylcholine levels. And those are two neurotransmitters that, yes, they're in our brain and our nervous system and such, but they are also key to muscle function in the gut. So that would be the reason. This is why you constipate when you take codeine. And so you have this problem with your OxyContins and your Percocets, etc., your Percodans. Those all have codeine in them. So, I'm not a walking textbook on opioids and the other ones. I mean, I've heard of some of them like Demerol and Vicodin, but I'm not really sure what's in them. But it's going to be something else that's similar because they operate on the similar level in the body. Even a chronic mineral imbalance can lead to poor motility. And levodopa, which is what the Parkinson's patients take, affects gut motility. And I find that one really interesting because there's a link between developing Parkinson's and having a gut dysbiosis. There's already been a link showing that Parkinson's people have dysbiosis to begin with. And now, once they're diagnosed with Parkinson's, they're getting levodopa, which is going to continue to affect how their gut functions. So the reason I wanted to do this one in particular and why I think it's so important, that's a lot of drugs. And plus we have the antibiotics, plus we have the birth control pills, plus we have the corticosteroids. The history that you take with your client is going to have to be more thorough and see if you have any of these in not just in their present, but in their past, especially those opioids. There's a lot of people, they may not be on opioids now, but if they've had surgeries or any kind of painful accident or anything that's caused them a lot of pain, they've probably been prescribed an opioid of some kind. And how long they were on it is a factor. And, you put some of the other factors in, it doesn't take much before you've created an opportunity for poor gut motility, dysbiosis, and upsetting the whole balance of their gastrointestinal system. Okay, so our protocol for SIBO. So the first thing we want to do, of course, is to improve gut bacteria diversity. This is going to involve antimicrobials such as oil of oregano or grapefruit seed extract. We also want to eat prebiotics and probiotic foods because, again, that's all going to help with the gut bacteria diversity. We're going to want to have them take probiotics. And again, there's lots of good probiotics on the market that would be suitable. But there's also the spore probiotics that are becoming popular now. They are helpful too. And there's different brands out there. So some are doing a combination of both. Some companies are doing a combination of both probiotics and spore probiotics. And what a spore probiotic is, and the big claim for the spores is, they're not native to the to us. If you're familiar at all with what they call the soil-based organisms theory, where you're getting these organisms from the soil, and they're helpful to us while they're in us, and then they just kind of pass through us. Well, the spores kind of fall into that category. They are actually found in nature. They're in a spore form, so they're not in their active form, which means that they don't sort of activate till they get to the gastrointestinal system. This is how the information is presented by the spore companies. And there has been some really good research, especially in Europe, about their benefits. And certainly they're worth trying. And I know several companies are starting to add spore probiotics to their probiotic products. Some are strictly spores, and some are a combination. The second thing you want to do for SIBO is to improve the mucus lining and the gut motility. So things like soluble fiber, flax seeds, chia seeds, oat bran, psyllium, legumes, fruits and vegetables, these can all increase the soluble fiber in the diet and improve the transit time and the gut motility. They also are a lot of them are very soothing for the mucus lining as well. You want to get more resistant starch into them. Resistant starch produces butyrate. So essentially, you eat resistant starch, which are found in potatoes, grains, legumes, corn, sweet potato, a lot of other foods, quinoa, and you eat them, and your bifidus bacteria eats the resistant starch. Resistant starch is a type of fiber. And so the bifidus bacteria in the colon eats it, produces the short-chain fatty acid butyrate, which is very good for the mucus lining and gut motility. So if your clients have problems with, say, certain foods, and it's hard for them, especially if they're low in bifidus bacteria, they may not be getting the butyrate produced because they don't have enough bifidus bacteria. In the short term, you can actually take the supplement butyrate. Genestra, in particular, has a butyrate supplement. My new favorite is hyaluronic acid. It's really good for the gut, along with joints and skin and brain and all kinds of things. But it helps with gut motility. And then chondroitin sulfate, which was interesting to me because, we only typically hear of it in combination with glucosamine sulfate for joints, but they've actually studied it, that it helps lower inflammation in the gut and helps with the intestinal wall lining as well. The same is true with hyaluronic acid and butyrate. They're both linked to lowering inflammation, amongst other things, in the gastrointestinal system. And then here are some other foods that can stimulate gut motility. Coffee. So if you're a coffee drinker, that probably makes you happy. Ginger root, garlic, magnesium, and exercise. And I also thought we should mention chewing if we're talking about gut motility, because I found a study about chewing gum that they actually did a study on this where they had people chew gum after they had gastrointestinal surgery. So when you have gastrointestinal surgery, it interferes, of course, with your ability for motility. And so they had people chewing gum, and they actually found that they recovered faster and got function returning faster after surgery when they chewed gum. So they believe that it improves motility function. And of course, we know that peristalsis starts when you start to chew your food. So you're starting to signal the motility function when you chew your food. So teaching your clients to chew their food would be really, really helpful. And then the third thing is to increase a secretory IgA and Treg cells. So secretory IgA is a major inflammatory modulator. It's a major component of the immune system. And so if you have sufficient secretory IgA, then it helps lower inflammation. T regulatory cells, again, another component of your immune system. are important for two reasons. Number one, they lower inflammation, but they also improve immune function, especially in the gut, and in regards to immune tolerance. So immune tolerance is what you need to have so you don't react to foods, you don't develop allergies, you don't develop autoimmune conditions. That is all due to the value of your immune tolerance. And so Treg cells, the more Treg cells you have, the better immune tolerance you have. And the lower the Treg cells, the more you're at risk of developing allergies and autoimmunity and things. So this is going to be very helpful for negating some of the effects of the SIBO and what is the damage that's being caused by the bad bacteria to the intestinal wall lining. So to improve a secretory IgA, or sometimes they call it SIGA, you want more exposure to environmental microbes. So this is where you get exposure from the dirt, or maybe your pets or your family members, or, you know, it's not just about your native microbes, it's about exposure to microbes, both good and bad, in the outside world. Colostrum, which has become quite popular for gut health issues, would help with secretory IgA. The B vitamin choline, vitamin C, probiotics, of course, zinc, omega-3, all of these things would be helpful nutrients. And again, some of these you can get through food or in a multi or something like that. Moderate exercise is very good for it. And of course, stress reduction. To promote the Treg cells, there's the butyrate again. Plant sterols are very good. Vitamin A, omega-3 again, especially the DHA, turmeric, cumin seed oil, and getting proper sleep. So again, when we are looking at the overall picture of a client, you know, we have to look at their stress levels. We have to look at their exercise levels. We have to look at how well they sleep. We can't just be looking at nutrients. We can't just be looking at supplements. A lot of, I think what we do as holistic nutrition professionals strength is the fact that we look at these other issues and we try to create protocols that address them instead of just, you know, supplement after supplement. Okay. So in terms of a candidiasis protocol, we're seeing some similarities here, right? So candidiasis protocol will also have the antimicrobial oil of oregano or grapefruit seed or whatever, you know, there's different ones out there. Prebiotic and probiotic foods are good for a candidiasis protocol. Probiotics as a supplement are good. Glutamine, I've always been a big fan of adding glutamine. I found that it kind of speeds up the protocol and helps people feel better sooner. But there's other strategies that you can also use to improve the gut lining, which would be helpful in reducing inflammation and things. You remove food sensitivities if necessary. And of course, you also want to reduce the overall inflammation of the gut. So again, the butyrate, the hyaluronic acid, the plant sterols, the omega-3. So you can see that much of what you would be recommending on a candidiasis protocol is very similar to what's on a SIBO protocol. And this is why it really doesn't matter too much which one they have, because you're wanting to do similar things, right? Now, the question happens, what happens if people have both? So is this possible? Well, the short answer, of course, is absolutely it's possible. You know, you could have somebody who has candidiasis and then because of poor gut motility or whatever, develop SIBO. The yeast is already over there in the first place, and now the bad bacteria is there as well. Yeast and bad bacteria work or live together more harmoniously than, from a proliferation point of view, than good bacteria lives with yeast or good bacteria lives with bad bacteria, because good bacteria is the adult in the room and needs to keep the, you know, the yeast and the bacteria playing nice. And so when the good bacteria isn't there sufficiently, then they can play all they like, and they don't seem to inhibit each other. So what you want to do is work on the similarities in both protocols. So the antimicrobials, the probiotics, the prebiotics, and probiotic foods would be a must. And you want to improve the mucosal lining and the gut lining motility, because those showed up in both as something that can happen. So, you know, you can work on that as well. You want to lower inflammation, because both involve inflammation. And again, you want to look at lifestyle, sleep, exercise, and stress, because they're going to be playing a role in both conditions. Now, for those of you who think, well, you know, you're not supposed to have oil of oregano or an antimicrobial with probiotics, it's absolutely not true. And this goes also will tie into our conversation that we had with regard to antibiotic resistant bacteria and antifungal resistant yeast strains. So what they have, there's actually quite a few studies where they've looked at the antibacterial remedies like oil of oregano and found that they have enhanced the bacterial infection healing process. And they are an effective means for preventing antibiotic resistant strain development, because what they have found is that the bacteria doesn't become resistant to them. There's other studies that have found these same results that I've listed here. Plus, they've also found that oil of oregano does not affect your good bacteria strains, which is what a lot of people have theorized, but they had no proof for it. And it turns out there is no proof for it. And so we have to respect that, you know, oil of oregano and some of these substances, they are quite potent outside the body, but they're not as potent inside the body. So when they go through the gastrointestinal system, they are met with enzymes and saliva and all kinds of things like that. They mean that they're not going to be as potent when they get into our gastrointestinal system. And they work differently than a way an antibiotic does. An antibiotic is a drug that was concocted specifically to kill inside the body. And the oil of oreganos or the grapefruit seed extracts were not. So they don't operate in the same fashion. They help inhibit bad bacteria, but they don't necessarily have an effect on the good bacteria strains. And I'm thinking, again, it's too soon because this Candida auris is too new, but probably we will find out that the oil of oregano or the grapefruit seed extract or any of the natural antimicrobials will have a similar effect with as an antifungal on strains that are proving to be, antifungal resistant. What's the word? What am I looking for? Antifungal resistant. Yeah, that's right. So they're resistant to the antifungal drugs. So I'm hoping that helps you put this into context. If you're thinking, well, why would I be giving them oil of oregano if I'm giving them probiotics? It's not a problem. Okay, so there's a lot of supplements mentioned, right? So I know that doesn't look good or sound good, and it makes it more confusing. So what I recommend is you pick one at a time. Other than the antimicrobial and the probiotics, which are a must, just pick one. Just if you want it to be butyrate, or you want it to be hyaluronic acid, or you want it to be glutamine, or, basically just pick one. Have them do a bottle of that, see how it helps them. If it's helping, great. If they seem to stop improving, then you try another one. You may want to add a second one at some point, depending on the client. But there's nothing wrong with just, okay, now you're on glutamine. Next, you're going to try hyaluronic acid. Now we're going to try butyrate. Like you can do that. You can put them on a multi to get some of the vitamins and minerals in if you like. But you don't have to go hog wild with the supplements. And some of the supplements I mentioned come in food form, so certainly you can add more omega-3 into the diet. You can have turmeric in the diet. You can have cumin seed oil. So these are all working on a diet level. And it's very important that we always remember that in general, if a protocol is working, supplements are temporary. And so they are not the end goal that we need to have. It's the food and lifestyle that are going to be permanent, and for their long-term benefit. So if they manage to get rid of the SIBO and the Candidiasis, what's going to keep it away and prevent other problems from developing is the food and lifestyle changes they make. So this should always be the biggest focus. Now, there is some diet controversy with regard to SIBO and Candidiasis diet. There's many who say it's the same diet, that's the good news. And basically, they describe it as a low sugar, removing the processed foods, increasing the whole foods. That's basically if you want to just summarize them up in a sentence. However, there are some SIBO diets that say no grains or fiber, and there are Candidiasis diets, of course, that say eat grains. And when I was doing some of the research for this, I came across chat rooms where people are saying, I've been diagnosed with Candida and SIBO, and one doctor says don't eat this, and the other doctor says eat this. I don't know what to do. I would stick with the diets are the same scenario. That's what I would do. I would be the low sugar, remove processed foods, and create whole foods. What you need to do is when you're dealing with the individual client, you need to get to know them. You need them to do a food journal at the beginning, see if you can identify maybe there are a food here or there that is particularly problematic with them. And that is a conversation you have with the client as to what you're going to do about it. I wouldn't get hung up on some strict SIBO diet or some strict candidiasis diet. The big key is the antimicrobials and the probiotics. And then finally, you know, both of these protocols can be very overwhelming for a client. And so what you want to do is help the client make the best food and lifestyle choices that they can, but don't get hung up, or don't let them get hung up if their choices are not perfect, right? This is a long game. And so there needs to be some flexibility. You want to start with the antimicrobial and the probiotic, as I mentioned, and then add other supplements one at a time. And that way you can measure whether A, they're reacting to them in any way that's negative, or B, they're noticing any benefits. And make sure that the client understands this takes time, and don't make it too strict for them, because this will help keep them compliant. And again, this is a long game, so they want to stay compliant. You want them to be happy with the food choices they're making. You want them to like their food. You want them to enjoy it. And you want them to enjoy the lifestyle changes that they're making. So you just keep that in mind when you're trying to put them on a protocol. And that's the end of my presentation. So now I'm going to come back to you guys. And I have to turn off screen share. And there I am. Okay. We have questions already. You guys have been busy, and you've been talking to each other. I hope you were listening to me. Okay. I will send the replay. And I'll even send you the PDFs, okay? All right. Can the ileocecal valve be damaged by colonoscopies? Possibly. Generally, no. Generally, they don't go up that far, but there is a possibility that, you know, anything can happen, right? So I wouldn't say it's common. How do we know if there is slow gut motility? Does it just show up as constipation? What about if it's just slow motility in the small intestines? Hard to do. I mean, you can do the transit time. That gives you a good clue. When does the food show up in the, like something that doesn't digest, like corn or beets or whatever? When does it show up in the toilet? But you have, and this is the really difficult part, you have situations where one section moves well and the other doesn't. And you can also have where one section is moving too fast and the other isn't. Or one's, you know what I mean? Like there's permutations because it depends on the quality of the muscle in the given section. So it's a very hard thing to tell. So one of the reasons I was giving you the reasons for slow gut motility is because you could use that as a way to determine if it's a possibility. So you have the drugs, you have the surgeries, you have the poor quality diet, you have the antibiotics. So you have all these different factors that can contribute to gut motility, and therefore look for one or more of them. So obviously if somebody's on a hardcore opiate, they're going to have a gut motility problem no matter what. But what if it was in their past? Well, what else are they doing? Did they do anything that improves gut motility? And then look at those foods. You know, somebody who drinks a lot of coffee, generally that's, you know, that stimulates the gut to make you poop. So that's, you know, it's always a balancing act. So So how much of the bad do they have versus how much of the good do they have, right? And so you have to kind of look at it. This is why you need to take good client intake forms or have good client interviews. You don't necessarily have to put it all down in a form. You just have to make sure you have the questions ready to ask when you're interviewing the client in your first session, so you can get a picture of as to what they're doing. You know, somebody who eats a lot of garlic and you know, ginger and exercises and, you know, things like that is less likely to have a gut motility problem. They may even be on an opioid and it doesn't affect them. So you've got to look at the totality of it. All right. So I'm just reading what Eva said. I think something can manifest as an overall symptom, not just in the small intestines. Okay, well, I already answered that. When you say cumin seed oil, do you mean black cumin seed oil? No, I mean black cumin seed oil. Mike says, oh, because that was for transit time. Cooked beet, yes, or corn. What brand and dose of oil of oregano do you recommend? I really like Headwind. That's the brand. I follow the instructions on the bottle. Shannon's asking, yeah, I'll send out the PDF of the slides as well. Don't worry. Yeah, you have grapefruit seed extract, you have garlic, you have clove, you have olive leaf, which Suzanne has mentioned. There are many antimicrobials. Lavender, if it's food grade. There's a lot of things. Sometimes they're formulas you can buy, which is fine. And so somebody's formulated them into a, you know, put a bunch of them. They work well. You know, the goal is some type of antimicrobial. Says, Melody's asking, how long would you have to be on the supplements for? Depends on the severity, but average 3 months, 6 months, 9 months, 12 months. Okay, so normally what I do, and anybody who's in healthy gut, you just look at the Candida protocol and you can see what I recommend. But for those of you who are not, I start them off with the antimicrobials and the probiotics. And the probiotics is usually fairly high dose, 50 billion or higher. And then as they improve, and you're looking for gastrointestinal improvement, so maybe gas and bloating is reduced, or maybe the stools have changed, or, you know, something's changed that is noticeable to them. I sort of will, you know, maybe wean down on the probiotics if that seems appropriate. And I do like to switch around the antimicrobial. So if they've been on oil of oregano or they've been on a kit for a couple of months, then I might switch them to grapefruit seed extract. Or I really like olive leaf for Candida, just for the record. It's actually my favorite. And that way, if there's something that olive leaf does that oil of oregano doesn't do, they're getting the benefit of that. And the problem is, it's all dependent on the client. As you said, Melody, what is the client feeling? And usually when you have either SIBO or Candidiasis, you've got two problems. First, it's helping to restore good bacteria levels. So when you take the probiotic, that's just helping temporarily. It's not going to, they're not going to repopulate inside of you. They're just helping you while they're there and they're passing through. So it comes down to how well you are repopulating your residential bacteria. So that's part of it. But the other part is this damage to the intestinal wall lining, the mucus lining, etc. If that's not sufficiently addressed, and that would be the longer situation, then they're still going to have a lot of symptoms. They're still going to be inflamed. They're still going to have food intolerances. And so you're looking at months. You're looking at months. But it doesn't have to be super restrictive. It doesn't have to be multiple supplements. And that's what you're going to have to work out with the client. So even if they're on, say, a low-dose probiotic, maybe you've stopped the antimicrobial, but you're still doing, you know, a glutamine or a hyaluronic acid, or you're rotating around those, or a butyrate or something like that, so that they continue to improve. As long as they're doing the diet, they're going to see a steady progress. And the problem is we don't know how damaged they are. And if we don't know how damaged they are, we don't know how long it's going to take. So the goal is to keep the substances they need that will help them repair in them in a manner that's not it's not interfering with the quality of their life, because that's when they try to get a little antsy. Okay. So the protocols are basically the same. Yeah, that's basically it. And that's the good news. That's the good news, because if you don't, like if you want to, you can't diagnose them anyway, right? You can't tell them they have candidiasis. You can't tell them they have SIBO. But say you have access to some type of testing that allows you to test for that, or say they've been diagnosed by some other practitioner. Doesn't really matter. In the end is what's going to fix them. That's all they care about. They don't really care what candidiasis is, and they certainly don't care what SIBO is. It's like, how do I get rid of it? And quite frankly, the less labels they have, the better it is for them psychologically. You know, and if we don't tell them, because we're not supposed to say you have candidiasis, even though we suspect it, but we can say these things are very helpful for, you know, some of the symptoms you're complaining for, and let's give them a try. And that gives them hope, and that keeps them in a positive framework. And I think it gives them more of a positive framework than if you tell them, not that we would do this, but if somebody else tells them they have a condition, which they're going to call a disease, and then they're going to be freaked out by it. Okay. Jessica's saying that would be dependent on the individual. Best way to see. Yeah, good. Helen says, why would an antimicrobial cause constipation? Would this mean you need to keep trying different antimicrobials? I would look at all the other factors that cause constipation. So what's their water like? What's their fiber like? What are the probiotics like? And generally it shouldn't cause it. But yeah, if you can't find that they're missing something in the overall picture for constipation, could be the gut motility as well, then try a different antimicrobial. I mean, there's so many to choose from. Helen, sorry, the brand I mentioned, I think I never gave you guys my phone number. I typed it, but I didn't hit the enter. Headwind is I'm probably spelling it wrong, but anyway, is the brand of oil of oregano I really like. Okay. But what was that? Okay. Helen's asking, because I put a picture of Pure Encapsulations colostrum, is that what I'm recommending? You know, I have brand favorites and I rotate, right? So right now, Pure Encapsulations is in my list of brand favorites. So since they had a colostrum, I picked that one as the picture. Plus it was wider as a bottle and that looked better on the slide. It would certainly be, if I was going to recommend colostrum, it would be one of the brands I would choose to try first. It is a very good brand. What have you seen with the efficacy of what's that? RIFAXMI and SIBO? I don't know what that is. Karen, what is RIFAXIMIN? If you can type in the chat, I'll answer that question. Susan says, I had my gut bacteria checked by uBiome, and they found I was very low in 10 strains of good bacteria. Is this related to SIBO? No. So they're only testing your poop. I've had the uBiome test too myself. So they're only testing your colon bacteria, not your small intestines. There is no test for small intestinal bacteria at this point. But what that does show is it doesn't necessarily mean you have dysbiosis. It means that those particular strains are low, and if those particular strains are related to a particular function or nutrients that you need, or something like that, because every strain has different functions, that could be affecting you overall. So you want to build up those strains. And that you can't do that through probiotics, but if you take probiotics that are similar to those strains, like they have the same name. They're not necessarily the same strain that's in you because we're all unique. That can help with the function. And then feeding your more good bacteria to your gastrointestinal system over time may help you. So I hope that makes sense. This is the biggest problem we have right now is what do you do when you know certain strains are low? How do you build them up? Yes, if you can find probiotics that do similar things in the strains that they have, that's helpful, but the probiotics aren't restoring your overall gut residential bacteria. So Karen's asking, do I recommend low FODMAPs for Candida or SIBO? Generally, no. The only time I would ever even encourage it, and this is why I prefer to do a food journal to sort of see if we can figure out what's bothering them. There's too many foods that are removed on FODMAPs that are really, really good prebiotic foods, because that's basically what they're reducing, they're removing a lot of prebiotic foods. So it may be helpful to some people in the short term, but in the long term, it's not going to restore their overall gut health. And so if I don't have to do it, I wouldn't do it. Now, if they come already on that, there's nothing you can do about it. And there are really good other foods still available. But what we're learning about gut diversity and the microbes is different foods feed different strains. We don't have a map for them or anything like that. So you can't just say, oh yeah, I've got a prebiotic in my probiotic supplement. That's not enough. It's much more complex than that. So you need the phytonutrients from the different foods, and you need the fibers from the different foods and things like that. And the problem is that generally, you have to remember, when a person has trouble digesting a food, it means they're missing the bacteria that helps digest the food. So so it's kind of a catch-22, right? It's really hard to figure out how to get around that. So this is where the probiotics can help in the short term and some of the other types of supplements. But generally, I avoid any kind of set protocols. I really want to work with the client one-on-one and try to find out the best solution for them. And it is possible with regard to FODMAPs that not all of the FODMAP foods that they have to remove are problematic for them. So I would even, especially if they've been on it for a while, they've come to you already on it, I would actually experiment, and you're doing this openly with them, right? You're saying, so do you want to see if blueberries are okay. If you want to see if apples really are a problem for you, let's try one and see what happens. And if the answer is no, then you can put apples back in, okay? And you can put, that's how I would handle it. Have you found eliminating GMOs and anything that you might have and anything that might have had harvest, using Roundup helpful? I really liked the theory about how Roundup interferes with gut bacteria from what I've read. I liked it. And then I came up with a conundrum, which was, if grains sprayed with glyphosate, let's look at wheat, for example. So they spray wheat to harvest it before it's fully ready, so they have a uniform grain. And they don't do it to all wheat. It's only in certain areas where the growing conditions are not ideal. It's certainly not organic wheat of any kind. But I know that those same wheat strains are used to make sourdough bread, and sourdough bread is about bacterial organisms and yeast organisms proliferating. And so if the residues were interfering with our gut bacteria, why wouldn't they kill the sourdough so it wouldn't work? So I have a bit of a problem with that. So I'm just keeping a very open mind. I'm very much avoid GMOs, period, as a principle. We don't know enough about them. Unfortunately, you can't necessarily make the client go that route, but it's certainly something we can educate them on. It's certainly not something I ever buy. It's certainly not brands I recommend are, GMO free, and I would stick with that. I just don't know if it's as critical as the some of the information coming out is yet. I need to see more. Amio essential oils are amazing. Thank you, Nicole. That's a good recommendation. Yeah, I'm a big fan of essential oils as using as antimicrobials, especially if they're food grade. Mary's asking, what are your thoughts on cascara use and gut motility? Cascara sagrada is not supposed to interfere, unlike senna, and I'm not even convinced senna does either. But you know how they say that laxatives, especially the chemical laxatives, are going to interfere with your gut, the muscle contractions, and long term you become addicted to the laxatives because your own muscles don't work properly. I've heard that cascara does not do that. They have not said senna doesn't. I'm just having, worked with senna and stuff. I'm not sure it does. In general, I prefer not to use either senna or cascara, and I prefer things like triphala. I'll just put that in there if you're not familiar with it, which helps with restoring peristalsis. It's a an Ayurvedic or an Indian product, and it's 3 fruit powders together, which of course means it's food-based. And so I'm a big fan of that. And I'm a big fan of, I like the product Cleanse More from Renew Life, which I've had great results with people who cannot poop unless they take senna. So if somebody's on cascara or on senna, I would try to find something that worked for them better that wasn't either one of those. I know there was a question about what brand of hyaluronic acid. Where did that go? I don't know where it went. Anyway, my favorite hyaluronic acid right now is from a company called Hyalogic. And I actually take the one called Joints and Skin, and it's really good for the gut because it's hyaluronic acid. It's liquid. And I like things where you don't have to swallow a capsule. Okay. All right, so I got that. So Sandra's saying you couldn't say we're putting them on a Candida protocol or a SIBO protocol according to the RHN designation. That is correct. It doesn't matter if they figure it out. And you could print off something and say, this is something you could go on. Does this sound like something you want to do? But that would usually scare them. So I prefer not to put a name to it. I don't like putting names to it because in the end, we're trying to get them to change how they see food, how they live their life. And, the less labels that are put to things, the more it's just about, hey, does this help? And it's amazing how much more that keeps them in a positive mind frame. Okay, have you found, okay, I answered that one, there we go. Answered that one. Is the colostrum from humans? No, it's from a cow. So colostrum is usually New Zealand sourced cows, which are considered cleaner than others. Rifaximin is a drug used to treat SIBO, and it's an anti-diarrhea, somebody said. That doesn't make any sense to me whatsoever, because slow gut motility is more likely linked to constipation. So Karen's saying it's an antibiotic. Oh, that makes more sense for treatments for SIBO. It's only supposed to target the small intestines, I've been told. Yeah, they're starting to, I don't know how you do that. They're starting to do more targeted antibiotics to try and limit the use of the broad spectrum antibiotic when they know they've got the right situation, because they think the broad spectrums are more involved with the antibiotic resistance. Again, if they're on so anytime anybody's on an antibiotic, I don't care what it's for, put them on probiotics simultaneously, absolutely, 100%. That scenario I showed you in the diagram that showed the difference in microbes just after being on antibiotics, there are other studies that have shown that when the probiotics or with the antibiotics, the decrease isn't so severe, and the recovery time is much better. So if they're on those drugs, put them on the probiotics right away alongside the drugs. And if they've been on the drug for a while, well, that's a little more problematic, but you're still going to have to do the same things, right? So you might not put them on the antimicrobial to start because they're on the antibiotic. That doesn't make sense in the short term. But really start them on the probiotics and building up the gut bacteria as best you can. And then once they're off the antibiotic, pay attention to symptoms. If they see symptoms are coming, then they might need the antimicrobial down the road. There is some good information that shows that if you can limit the damage of the antibiotic, that a lot of times you can speed the healing with the antibiotic. You just have to watch out for the other damage that it does. So now you have a better idea of some of the other ways it causes damage. Your client's also taking digestive enzymes. I don't have a problem with that. If that helps them digest better, that's good. Okay, so Sandra's saying the current treatment of SIBO involves starving the microbes using an elemental diet and amino acids plus glucose or specific carbohydrate along with specific antibiotics and herbal antimicrobials. Well-known doctors such as Dr. Siebecker don't feel SIBO can be alleviated with just antibiotics or herbal antimicrobials. Can you address this? Well, I think I did address that. So I think if we have the antimicrobials and we have the probiotics, but we're also doing the gut motility work, we're also feeding them foods that will help the good bacteria, reproduce and such. I think all of these are part of them. If we're looking at the sleep, if we're looking at the exercise, and again, those type of diets never do that. They don't look at sleep. They don't look at exercise. They don't look at stress. They don't care. I call it using food as a weapon. They come up with these food protocols when really the work's being done by the antimicrobials and the probiotics. That's what's really doing the work. But if you just put someone on an antimicrobial and a probiotic, but they're having a refined food diet, and they've probably been on antibiotics in the past, or maybe they were on a course of antibiotics before they, got to this point, whatever, you're asking the antimicrobials and the probiotics to do a lot. So it's got to be all components. And I don't think you need those strict diets. I've never needed them. I haven't needed them for Candida. I haven't needed them for SIBO. Never needed them. So if I've never needed them, I mean, I can't have just the only clients who didn't need them. So that doesn't make any sense. So I just think because you remember your client is one-on-one with you, and you're building a relationship with this person. And if you can make it so that it's not, because they got to be on it for a while, you can make it so it's not so problematic for them in terms of their lifestyle and how much they enjoy themselves, I think that's really, really helpful. I think that's the best way to go. And you're going to have a much more positive attitude in your client, which is essential for recovery. Okay. Rifaximin is a drug name, so it's trade name in Canada. Both are the same drugs. Naturopaths are prescribing it more and more for SIBO. It's 99% not absorbed into the body and works specifically in the small intestine for SIBO, as previously said. It requires bile to work. It's not supposed to be active in the large intestines as there is less bile. The dose is usually 550 milligrams 3 times daily for 2 weeks and is an alternative treatment to SIBO versus elemental diet or straight antimicrobials. Again, yeah, it's a drug. I'm not against drugs per se. I think in limited use, if you also understand what the drugs do and what they could be affecting in a negative way in terms of how the body functions, if you can negate that through foods or other supplements, I think you might see a quicker recovery. So personally, I mean, I'd like it if nobody had to be on a drug. But I've also seen cases where using the drug short term in acute, while supporting the body to help it prevent the damage that the drug may cause, in a bigger picture, is a strategy that can be used. And I'm not opposed to that. And I don't think we should be opposed to that. What we don't want is for the client to say, okay, I take this drug, I do this for 2 weeks and blah, 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 and then I'm good to go, because their long-term perspective is getting the proper foods into them and the proper lifestyle into them so that their intestinal tract functions ideally as best we can help them do it, and that it prevents future things from happening. So I think, we always have to, again, we're lucky that we get to individualize and we get to have a one-on-one conversation with the client. And I think we have to be open to working with them as best we can. Susan asks, what would you recommend for diarrhea? I typically recommend soluble fiber, slippery elm, and probiotics. And a lot of good research for probiotics and diarrhea. Kayla's asking, is oil of oregano the same as oregano essential oil? That's exactly what it is. It's an essential oil. Kate says, thank you, gotta run, see you soon. Okay. Heather says, now something very different. Very few people are talking about lectins and the damage they do to our gut bacteria. Also, I've read reports that Monsanto has genetically added lectins to their seeds. And do these have to be labeled as GMO? Are you familiar with the work of Stephen Gundy? This is new research, eyes wide open. Okay, so I'm not a big person concerned with lectins because there's two schools of thought. One is, first of all, if you have sufficient gut bacteria, lectins will never be a problem for you. Second, if you ferment the foods that contain lectins, so you can ferment grains, you can ferment legumes, you can ferment these things, that will take care of the lectins. So we're more, I'm concerned with, more of a whole food perspective because I know those foods are very important. Now, if Monsanto is up to no good, which they often are, I will look into that. I don't think technically if the lectins are natural to the seed, the fact that Monsanto has, if this is what's occurring, the fact that they've increased the lectins in those seeds, that is a hybrid, not a GMO, and no, it doesn't have to be labeled. But I'll look into this. I'll look up Stephen Gundy and see what I can find out. But generally, I'm very much about how do we digest foods optimally, which means you're talking about having sufficient gut bacteria and, of course, having sufficient fermentation ahead of time if you don't have sufficient good gut bacteria. And that's something that people have to understand. When you ferment the food ahead of time, you save the body from having to do the same thing, right? Because that's what our gut bacteria does. Okay. I will read about that. Susan says, I tried rifaximin twice, no changes at all in the SIBO or the diarrhea. Well, hopefully you've got some new things to try now, Susan, and hopefully that would be beneficial to you. Susan says, colostrum is supposed to be quite helpful. I'll just copy this. Almost has put in this link for lectins. Again, I think a lot of the lectin stuff is a little bit on the like people get a little carried away with it in some of the sites I've been on, but I've copied that so that I can look at it when the webinar ends. And Susan says, I love it that you choose real food over supplements and drugs. Well, that's what we got to get. Oh, Grundy. Okay. Thank you, Heather. Okay, so she typoed Dr. Stephen Grundy. I will look up his research. Yeah, well, I we have to live, right? We have to be happy. And, the biggest problem people have is they have this idea that you can eat whatever you like and then just take a drug or a supplement and you're going to solve your problem. And it just doesn't work that way. And it's our goal. And a lot of what we recommend as foods taste really, really, really good. And in a good recipe with, you know, herbs and spices and things like that, we're actually giving them fun. We're giving them flavor. And it's our job, I think, to, you know, convince them of that, to make them understand that, you know, we're not trying to torture them. We're trying to help them find something that works really well for their lives, right? So both for the way their body likes the food and how it fits their lifestyle. And I think if we do that, we're going to have very happy clients. And if we have happy clients, we're going to have a happy business. Okay. Okay. So Eva says, thank you for the information. Would love it if you did a webinar on info on gluten. So sometime. Okay. I will add that to the list. I already have, I don't know if you saw the email I sent out yesterday. In October, I want to talk about birth control, and I've got some really good information about what it does on the gut, and then some alternatives to birth control, and then I've got some new brain gut information, which will be November, but maybe I could do gluten in December or January. All right, so I think that's the end of the questions. I'm getting the thank yous. That's usually a good sign you're all done. Thank you very much for attending. I've got a really good turnout on a Sunday afternoon. I think this is a good time for people. And hopefully, yes, she's going, Ricky Heller is promoting anti-Candidiasis. Is she an RHN? Yes, she is. I taught Ricky. So, so I know for a fact she's an RHN. Okay. Everybody's saying thank you. And I guess I will see those of you who sign up for the next one, and have a great Sunday afternoon. Okay.